So that's what college was up there. So.
I routed it through in order to get it to record onto OBS. OBS. Have a means, at least to record.
I didn't know you had a medical director. Yeah, I really nominated somebody.
Nobody got a rope.
Exactly. Exactly.
I don't blame him.
What's that? Look good? Looks good, looks sharp. I'll try to grab something while I still can. I've only got about 3-4 minutes.
Thank you, everyone, for taking your seats. Good morning. We haven't started, we're already behind. We want to give you a warm welcome to the 2025 SABM meeting here in Minneapolis. I'm Jen Andrews from Vanderbilt, and my meeting planning co-chair is Dr. Jacob Raffel from Thomas Jefferson University. We want to thank all of our sponsors and the SABM board of directors for their strong support for our meeting. We've planned an excellent meeting over the past year for you, and our program is just fantastic. We're really excited about this year's keynote speaker, Dr. Weyand, who is also a pediatric hem-onc doctor like myself. She's much more famous than I am. She is referred to as a Shematologist, so we're really looking forward to her session this morning. A few friendly housekeeping reminders. The restrooms are located through the atrium behind the exhibitors. Please silence your pagers and phones if possible. Please enter and exit quietly if someone is speaking to decrease distractions. Please be sure to download the WAA app if you haven't already. It's a nice way to check in with your peers and take advantage of this opportunity to network and connect with those who share your interest in PPM. Please consider becoming a hospital affiliate of SABM. There are many great benefits, including free SABM memberships and annual meeting registration. Check their website for details. The numbers of registrants, etc., depends on your level of support. Also, your hospital will be visible on the SABM website where patients and families research hospitals with PPM programs. A reminder that the first break is at 9:30 a.m. right outside the atrium with all of our exhibitors sponsoring the meeting.
So next, We'd like to introduce our hospital sponsor, the Mayo Clinic. Dr. Matthew Warner will be speaking on Mayo's behalf. Dr. Warner is an anesthesiologist and critical care physician at the Mayo Clinic here in Minnesota, located actually mainly in Rochester, and he holds the rank of academic of associate professor. He has dedicated his career to the advancement of patient blood management for the organization and improving patient outcomes. He serves as the chair of the Mayo Clinic Patient Blood Management Subcommittee and the medical director of the Mayo Clinic Patient Blood Management Program. He also founded and directs the Mayo Clinic Preoperative Anemia Clinic and the Mayo Clinic Bloodless Medicine and Surgery Program. Dr. Warner serves on the Patient Blood Management Committee of the American Society of Anesthesiologists. He is the past chair of the Society of Critical Care Anesthesiologists Research Committee, and he is highly active in clinical and translational research in the space of anemia and blood therapies. He receives federal research support through the National Heart, Lung, and Blood Institute of the National Institutes of Health to study anemia, development, and recovery in survivors of critical illness. And he's also the president of our organization, SABM. After that, Derek Hughes and Lydia are going to be speaking to us. Derek is the co-founder of the WAA and Human Touch Media Foundation, and Lydia Delaney is the Global Communications Director of the World Anemia Awareness and Human Touch Media Foundation. World Anemia Awareness is an award-winning social impact organization focused on educational global campaigns for blood health awareness in over 155 countries. They publish the award-winning international bestseller Blood Works and Owner's Guide. But first, we have a surprise welcome message from the governor of Minnesota. And thank you, Dr. Warner, for engaging and arranging this video. So let's please welcome the governor of Minnesota on this coming video.
Good morning, everyone. Governor Jim Walz here. It's an honor that so many leading clinicians, researchers, and healthcare professionals have gathered here in Minnesota to improve patient outcomes and to make the practice of medicine safer, smarter, and more compassionate. I especially want to thank the Mayo Clinic for sponsoring this important event. Mayo is not just a Minnesota asset, but a global leader in innovation, discovery, and patient-centered care. We take great pride in being a place where healthcare innovation thrives, whether it's at Mayo, the University of Minnesota, our community hospitals, or the medical technology companies that are across the state and decided to call Minnesota home. This is a place where people come together to find better ways to care for patients, and that spirit of collaboration is exactly what this represents. Your work is vital. Patient blood management is about putting patients first, ensuring that they are at the center of medical decisions. Through your work, you're ensuring that every resource in healthcare is used wisely and responsibly. I want to thank you for the work you do every day to advance this field and for the dedication you bring to the patients and families who count on you. I hope your time here is both productive and inspiring, and I wish you all the best for a successful conference. Welcome to Minnesota, and thank you.
Thank you.
Good morning, everybody. Good to see you all. Thank you for coming to Minnesota. It's a pleasure to welcome you in my home state. You know, Jacob said a lot of nice things, but the only thing that really matters is I'm number one on the WAA app. Leaderboard. So if you don't have the WAA app, download it. I don't know how I'm number one, but that means not a lot of people are engaged, so please engage. Anyway, Mayo Clinic is about an hour south of here in the town of Rochester. Just a little bit of information about it. We're really excited to be here. It is the first and largest integrated group medical practice in the world. We have over 4,500 staff, physicians, and scientists, over 65,000 allied health personnel. We see over 1.3 million patients each year, and we're the largest employer in Minnesota. Surgery is something that's near and dear to my heart as an anesthesiologist. We do a lot of surgeries. We do over 70,000 in Rochester alone. So for those of you that are coming to tour on Saturday to Minnesota, down in the Mayo Clinic. Excited to show you some of the spaces where we do some of this work. Hospital rankings, take them or leave them, but Mayo is consistently ranked #1 in the nation and #1 in the world. It's been that way for at least the last 8 years. The reason that we invest in patient management is because our primary value is the needs of the patient come first. And patient management is just one way to move up to that sort of expectation. For those who don't know the history of Mayo, there was a huge tornado back in the late 1800s. It wiped out the small town of Rochester completely. Over 37 people were killed, over 200 were injured. And so there was a nursing order there, actually Sisters of St. Francis. This is their beautiful monastery on a hill over Rochester. And they were trained, they were not only Catholic nuns, but they were also nursing trained. And so they led the efforts to care for these injured people. And they enlisted the help of 3 local physicians. This is William Worrell Mayo, who is actually a really short person. You can see him in the bottom there. And his 2 sons, Charlie on the left and Will on the right. And basically they started working with the sisters to care for all these injured people. And afterwards, the head of the nursing order of the Catholic, the nuns, the Sisters of St. Francis, said, we need a hospital. We want to work with you 3 to actually build a hospital. And that's what they did. This is St. Mary's Hospital. It was opened in 1889. It's been operational ever since. It started with 27 beds, now has well over 1,200 beds. It is just one of 2 hospitals in Rochester. The other hospital is also another big hospital that's like St. Mary's. And Mayo's actually building a new $5 billion hospital in downtown. So those that come will see all the construction happening to build the other hospital. But basically, this was a collaboration between the sisters, who were the earliest nurses, who actually ran the administration of the hospital and provided the direct care for patients, and the Mayo family, who basically were the ones providing the direct patient care for medical and surgical care. The Mayo brothers did something kind of remarkable for the day. They said, we need more expertise, and so they brought in people from all over the world who are leading clinicians and experts. One of them is this person named Henry Plummer. He basically was this just genius internal medicine doctor, and he invented so many cool things. So the medical record you know today, where a patient has a number, that was designed by him. He created the building that you see in the back, in the background there, lit up in yellow. That's now known as the Plummer Building. When that was built in the 1920s, it was like the most advanced medical building in the world. He developed all sorts of cool things, like a central laboratory, a pneumatic tube system, which we still use to send things between rooms. So anyway, it's now a National Historic Landmark. And again, if you come join us on Saturday, I'll gladly show you around. Another person that they enlisted was an anesthesiologist. The Mayo brothers were surgeons. This is John Lundy. He was the chair of anesthesiology. He actually established the very first blood bank at the Mayo Clinic in 1935. And so basically they'd keep blood in the OR with them. They'd store it for up to 14 days, and they provide it in small divided doses to their patients. Dr. Lundy, whether you like it or not, he was also the first to advocate for a hemoglobin transfusion trigger between 8 and 10. He said, let's consider transfusing patients who are considered of poor surgical risk. And that has very much stuck with us for almost 100 years now, that we're debating still, is that the right number? Basically, we're still where we started, but everyone here knows better. This is a picture of one of the first blood banks. You can see all the glass bottles of blood on the right, and that's Dr. John Lundy with his team. With that, just welcome. Really excited to have you here. Come stop by, learn more about Mayo. Find me or I think we have 8 or 9 people here from our team. Come stop us, come join us on Saturday if you can. Really excited to have you. Thank you for coming.
Pressure. Exciting. This is exciting. You know what's interesting about this event? It's a first-time event where SABM has lovingly decided to pull back, allow a virtual audience, a non-live audience, to take a peek at what's happening here. So that's exciting, right? Never happened before. Lydia, what kind of numbers are we looking at?
Maybe 3-4 million.
That's good. That's stressful. So that's the camera over there, right? That's our virtual audience. So now all of a sudden, so is my tie straight? Toothpaste on the mouth?
Just a little bit.
A little bit?
Other side.
The insecurities start to come out when all of a sudden it goes beyond a few hundred people in a ballroom, right? But what a lesson that blood health matters. It's a big deal. The global community dealing with iron deficiency and anemia, they want help. They want education. So we first of all want to just say thanks for being here. We've enjoyed very much our partnership, World Anemia Awareness, with SABM, the SABM family. Thank you to our current president, Dr. Linda Shore-Lesterson, and the entire SABM family for inviting us here. All the work that goes on behind the scenes. And I guess if you're kind of there, you're wondering, like, what actually do you see here beyond just the stage? And the simple answer is everyone's looking really good, right? Really good this morning. And what's going to happen today is we're going to have a global live stream, but this is just a sneak peek for the morning. And so we've got our keynote address, no pressure to our keynote speaker, right? Dr. Weyand, right? Our shematologist. And we're just going to enjoy that. But then tomorrow, there's a hybrid. You get the whole day if you have tickets. So enjoy that. It's an action-packed day tomorrow. But here we are with a lot of medical professionals and advocates and doctors and nurses. Have you ever had a medical professional say to you that sitting isn't good for your circulation? You ever heard that? So we got a really big virtual audience. They're going to be in their office, possibly in their bed or sitting on their sofa. What if we do the 15-minute morning stretch? You want to do that with me? Everybody up? Because we should lead by example, right? 15 minutes. Let's get the blood pumping. Here we go. 15 seconds. 15-second stretch. Did I say minutes? Gotcha. There we go. Reach for the Minneapolis sky. Beautiful. Everyone loves it. How about, like, punch the speaker in the head? How about that one right there? Everybody's favorite, right? There we go. Well done, everybody. The blood's pumping. You are examples of health and wellness. So, you're such good sports. So just a little context. We launched World Anemia Awareness Day a couple years back with our dear friends at SABM, and it has grown and grown and grown. And today we just wanted to kind of say thank you. And thank you specifically because for recent campaigns, including one that just finished for moms and babies, it was really interesting getting communication back from our global community. What is your connection with your medical professional? And all of them said the same thing. We struggle with trust. Do you have trust issues with your doctors, right? With your medical professionals? So what's the solution for that? Good communication, honesty. So that's what we tried to do. How did it work? Well, let's take a look. We'll take a look at our first video. Thank you. Gives you a few testimonials.
First delivery was an emergency cesarean section after very prolonged labor. I had major hemorrhage. This was 30 years ago, so there was much less awareness then of iron deficiency. And I think I spent the next few years absolutely exhausted. Sometime in that time, I also had a twin pregnancy and I was continuing with an almost full-time job. Looking back, if only I'd have known more then about iron deficiency, that I could have raised awareness amongst the doctors looking after me.
Actually, I was pregnant during my internship and I didn't have any rest. Was actually not eating properly. I was very tired, I was iron deficient. If only had known, I would have looked after my blood health better.
Personally, it just felt terrible. And I wish I had paid attention to this more. And the whole time I was myself iron deficient and anemic, I was paying attention to my patients, giving them advice about how to manage it, but yet normalizing it myself. I feel like had I paid more attention to it, I think I could have done a better job, both professionally and as a mom.
I've been part of, hundreds of deliveries before my own son was first born. You think, I know how to do this. I've delivered babies myself. I've done all the anesthesia care for deliveries. And then when your wife needs to have a cesarean delivery, very different. You're sitting there as a father. There's many things here that feel unfamiliar on the other side. Like there's things I never thought that a father might be thinking about.
When I was pregnant, which was 17 years ago, I did have all the symptoms. I had the fatigue, I had the restless legs. I was eating a lot of ice, but I didn't know what was causing that. I just assumed it was normal. My daughter does have a learning disability, and kind of knowing what I know now, I had all the symptoms that have contributed to that. I don't know.
For me, those signs that I wish I'd known, wish I had dismissed or ignored, none of them seemed to be connected to menstrual health at the time. But they obviously were. I wish I'd have known that the broader symptoms of menstrual health and what's normal for you, what's a change for you, it's essential.
Even though I'm professional, so to speak, right, as a trainee, hematology trainee, and I was not looking after myself, running around really, I didn't realize that how difficult, that 3 months postpartum, I end up having vertigo. The whole world is spinning. That is anemic. And that I myself, again, I tell you as a doctor, we always picked up signs and symptoms for patients, but never pick up signs and symptoms for ourselves. Huh?
She had a ferritin of 11, and we only found out after she's delivered my son. He's 8, and he's doing well. It's just that all of these thoughts and everything that we've talked about, you start going through your mind, and you can imagine how, navigating the system was challenging even for me. So you can imagine how this might be even more challenging for a patient who's not part of the healthcare system.
Even before I was diagnosed with anemia, I learned pretty quickly that as a patient, you have to advocate for yourself. I wish someone had told my teenage self to, even if I was afraid, to tell the doctors that I'm afraid and why.
My overwhelming distress was I had a premature baby in the special care baby unit who is intubated and very, very sick. And because I was a doctor, everyone assumed I knew that he probably would be okay, but nobody talked to me about his outcome. I was too scared to ask. So I did cry such a lot those first few months. With hindsight, I probably could have done with a course of antidepressants.
If only I would have known, I would tell myself that don't be embarrassed by having your period. It's totally a normal thing. Nothing is wrong with you. And I wouldn't have wasted one entire day sitting in a corner feeling that you're going to die or you did something wrong or something is wrong with you. You're fine. This is normal part of your life. And keep going.
When I became pregnant, I had a best friend who was also pregnant. She died of preeclampsia. We didn't know how serious that diagnosis was. To hold my best friend's newborn baby and to feel the unfairness of the fact that I get to rock her newborn baby to sleep and she'll never get to hold him was probably one of the most devastating things in my life.
As a mother, it's like, when you get pregnant, it's like, here's all the things you need to do, but no one necessarily explains why. We can't do this on our own. And that's where I would say, it's really important for women to have an advocate, whether it's your mother, whether it's another female friend, whether it's a doula or a midwife, and empowering women as to the why. Because I think it's too much of here, this is what you need to do, but not empowering the woman with knowledge to understand the why.
All right. Honesty. Stripping away the medical jargon and just opening up the heart and sharing honesty builds trust. So Lydia, you're in the production studio. You're doing front of house production and post-production. What was the reaction?
It was actually quite incredible seeing people speak from the heart about their own personal circumstances, and that, like Derek said, builds so much trust. People share that and they want to come back for more because they know they can trust this information.
Some people argue social media. Like, is that the best way to share medical education? Like, is it credible?
Well, is the news credible? You could say the same thing. Yeah.
So, who use social media?
If you look at TikTok, the World Health Organization, Doctors Without Borders, I've blanked on the other one.
UNICEF?
UNICEF are also on there, and they are sharing credible information to the public.
So a teenage girl is getting information in 2025. What's her first landing spot?
TikTok.
Yeah. Are we going to change that?
We can't change it, but we can provide credible information there so they can find it.
And a mom, where does she go typically?
Facebook.
So with so much muck, with so much information, how do you differentiate yourself?
There's so much misinformation out there, and it can be difficult. We've heard from some of the ones we interviewed that they try and find credible stuff and research. So if it's digestible and simple, clear, easy to understand, they've got a takeaway point immediately.
And when you look around this room here, people that have shown up for our campaigns, because we recognize some of the faces, like, how many people are actually watching this?
Right now?
Like, no, in general, historically.
Oh, into the millions. Yeah, easily up to, I think one of the highest was up to 7 million.
So that's amazing. So like, what's an influencer? Right? An influencer is someone that has influence over an audience. Is an influencer automatically an expert? Exactly. So people are thirsty for credible information. And what makes them come back for more? When it's honest and it's trustworthy. So did all of that honesty get results? Can we just roll our next video short? Well done, everybody. So somebody sees that and says, you know what, I have a voice, or I know other medical professionals that I'd like to recommend. What could somebody do, Lydia? Somebody that wants to help with the blood health communication that's happening globally?
Can just reach out to us. We want more credible voices to be able to share that. Tell us the challenges that you're facing. We can get that message out there. And we are having our Anemia-thon in February 2026, which we have a little, can we tell them?
Yeah.
A little sneak peek on our anesthesiologists who are often unseen, our smooth operators. There's a little shout out to them.
Have you hugged your anesthesiologist today? Okay, that's the question. Matt, hugs are coming. So that we're going to have a lot of fun with that, and we would welcome the communication. Lydia, thank you very much. Thank you. We well done, Lydia. She does so much. Yeah, so much behind the scenes. Thank you for that. So just in conclusion, for the virtual audience, we see you. Thank you. Who is SABM? Right. For so many, they have no idea who SABM is. So let's just touch on that in conclusion. In conclusion, you know how long SABM's been going for? Give or take, quarter century, right? I mean, we got an anniversary coming up next year. right? That's going to be exciting to see how we're going to celebrate that. But basically, we're talking 25 years. To keep a nonprofit going for 25 years in a sector that is so funding sensitive, what does that take? That takes some commitment from people who are not there for a paycheck, right? Dedication. Sherry just said, what did you say, Sherry? Xanax as well. So we just wanted to take a moment and talk about the behind the scenes of SABM. And we started by just asking a few SABM alumni, what do you appreciate about what SABM has done? Just gonna read a couple of sound bites. First one came from our current president, Dr. Linda. SABM creates a home for medical professionals of different specialties to come together and address common clinical challenges. Dr. Warner, who we heard from earlier, this was nice. SABM is a grassroots organization where anyone can get involved, receive support, and make lasting impact. For me, it immediately felt like home. Isn't that nice? Dr. Shander, one of the earliest pioneers of SABM, made this comment: "It's wonderful to see members come through SABM, change their practice where needed, and spread the knowledge." SABM, an organization that's been doing this for 25 years. Personally, when we work with SABM, we appreciate it because we see their heart. There's a commitment to a cause greater than the individual, greater than the ego, greater than the title, greater than the accolade. And it's beautiful to see, year in, year out. Now, of course, we don't want to put anyone specific on the spot and embarrass them at all, but it was interesting in kind of tabling comments from people. They all said the same thing. You should talk to Sherry. You should talk to Sherry. You should talk to Sherry. And I was like, I know, everyone's saying talk to Sherry. Why? And they said, because kind of when it started, there was a tiny little office and Sherry's car. And that's kind of how it started. And so it's really on the back of that sacrifice, so much of it unseen, definitely not for compensation, that we stand on those shoulders, right? And this organization, 2.5 decades later, is still going. So we take a moment to say to Sherry Izawa, thank you so much for all the great work you have done. We conclude by saying this: it's an organization, if you don't know them, get to know them. You can find them online, search through, find out what they're doing. This is the most exciting time in history to spread such important education on the topic of blood health, a vital topic. Thank you very much.
Thank you very much, Derek and Lydia. Really appreciate it. Now, Derek mentioned that influencers aren't usually experts, but we have an influencer and expert as our next speaker. So Dr. Angela Weyand, she's a pediatric hematologist. She's an associate professor of pediatrics. She's a co-director of a multidisciplinary clinic that cares for women, girls, and all people that are with the potential to menstruate for bleeding, thrombotic, and other hematological disorders. She has specific interests in iron deficiency, von Willebrand's disease, antiphospholipid antibody syndrome, hormone-provoked thrombosis. She's active in so many different things. It's even hard to get through the list here, but she's a member of the American Society of Hematology Health Equity Task Force. She co-chairs the Society for Thrombosis and Hemostasis Scientific and Standardization Committee on Women's Health. She's a member of the ISTH Guidance and Guidelines Committee. She's the section lead for the Lancet Hematology Commission on Women's Health, and she has so many other leadership roles. But really, if you have ever been on social media, you've likely come across the Shematologist. Dr. Weyand has done so many amazing things to spread the word about iron deficiency, anemia, women's health, and it's really such a treat and an honor to have her here. So thank you for joining us. And with that, this will be a perfect segue into her talk. So thanks, Derek, for setting it up so nicely.
Thank you so much for having me here today. I'm excited to be here. I'm not as tall as everybody else, to talk about something that I think is super important, which is women's health and iron deficiency, ironing out anemia, putting the FE in female. So I don't have any specific financial disclosures that are relevant to iron, but I do have academic disclosures in that I am the co-chair of the American Society of Hematology Working Group on Iron Deficiency, and also a member of the upcoming American Society of Hematology Iron Deficiency Diagnosis Guidelines. So just to kind of talk first, outline of what I'm going to be speaking about, I'm first going to talk about the clinical manifestations and epidemiology of iron deficiency, then change gears a little bit to talk about reconsidering how we define iron deficiency as well as how we define anemia specifically in women. And then lastly, try to highlight the importance of iron sufficiency in patient blood management. So many people in the room, maybe everyone in the room is quite aware, but iron deficiency is the most common micronutrient deficiency in the world. It's the most common cause of anemia. It's estimated to affect almost 2 billion or 2 billion people worldwide. That's billion with a B, numbers we can't even really comprehend in our minds. And it tends to affect populations that aren't typically prioritized, like women and young children. It is also the leading cause of life years lost to disability in women worldwide. As a hematologist, I think red blood cells are super important. Probably most people in this room think red blood cells are super important. And so when we think about iron and how we're taught about iron, especially in our medical training, we really think about iron as far as iron deficiency being a differential diagnosis for someone with anemia. And so we have a very red cell-centric view of iron. But it's important to recognize that there's actually a ton of other roles that iron plays in our body. Iron is involved throughout every system in our body, including things like being a required cofactor for synthesis of things like serotonin and dopamine, which most people would like more of. We use it in our muscles, we use it in mitochondrial functions, DNA and RNA synthesis. It's really involved throughout our bodies. And so we know that our bodies prioritize iron for hematopoiesis and erythropoiesis. And so a lot of these things can suffer before we get to end-stage iron deficiency or anemia. And so with that, our patients can really suffer a lot, even without being anemic, with lots of different symptoms that can be attributed to iron deficiency, including things like fatigue, restless legs, mental health issues, things like hair loss and nail changes, even changes in our immune function and thyroid function can all occur even before we get to end-stage iron deficiency or anemia. And I think everyone in the room is probably very well aware of the issues that are associated with iron deficiency anemia. Many, many studies across different populations have shown that iron deficiency anemia is associated with increased hospitalizations and length of stay. Across almost every different patient population you can think of, it's associated with increased morbidity and mortality. And even if there aren't such poor clinical outcomes, it's been shown to be associated with decreased functioning and quality of life, which are definitely things that we should care about for our patients. So how common is iron deficiency? Well, it's incredibly common, especially in people who menstruate. And this isn't news. We've known this for a really long time. So studies going back to the 60s, they took generally healthy people, and I'm going to come back to this idea of healthy people because it's an interesting concept, right, of how we define healthy. But these were college-age women that didn't have a lot of medical issues, and they did bone marrow biopsies to evaluate their bone marrow iron stores. And what they found was that a quarter of those patients had no stainable iron, and 37% of them had depleted iron stores. Many studies since that time have replicated these findings with anywhere up to half of women not having bone marrow iron stores. And that's not thinking about the iron that's in our tissues, all of our tissues throughout our body that also require iron. This is just looking again at that red cell-centric view of iron, looking at our bone marrow. We published in JAMA 2 years ago that this starts early on in people who menstruate. So this was a study looking at CDC NHANES data. It's a large national study where they collect laboratory data, clinical data, demographic data. And we looked at 12 to 21-year-old females. And depending on how you define iron deficiency, about 40% of 12 to 21-year-old females are already iron deficient. And this is a group that we do not universally screen, right? We don't actually currently have universal screening for any populations. We don't do dedicated iron screening in any populations. We have some hemoglobin screening when we have toddlers. We have hemoglobin screening when we're pregnant, but there's no universal iron screening specific to iron, despite very high prevalences in many groups. And it's likely that this high prevalence of iron is going to continue to increase for multiple reasons. So we know that due to societal issues, patients are going through menarche earlier, so they're starting to menstruate earlier. We know that up to 40% of people have heavy menstrual bleeding. And we heard a little bit in that inspiring video about how we don't talk about periods, and periods are stigmatized, and no one is aware of what a normal period is, so these people aren't necessarily presenting to care. We have less iron in our diets. All of us have less iron in our diets due to multiple reasons. We are eating less meat. That's a choice we're making. But also the foods that we buy at the grocery store. If you look at foods now compared to those same foods 20 years ago, there's less iron content in our foods. I don't really understand that entirely. I'm told that's due to depletion of nutrients in the soils. But either way, we are all consuming less iron than we were 20 years ago. There's increasing rates of obesity in our population, which we know decreases oral iron absorption. Women in general are having fewer pregnancies and breastfeeding for shorter amounts of time, and then also having later menopause. So all of these things together mean that over the course of a woman's lifetime, they're having higher proportion of their days are during times when they are in a state of blood loss. And unfortunately, it doesn't just affect the individual. So we heard some stories that were quite inspiring in those videos. This is an intergenerational issue, right? So you can imagine an adolescent with iron deficiency, all of the symptomatology associated with that. Often, undiagnosed, may be having some of their symptoms dismissed. Then as they get older and decide to have a child, they go into pregnancy iron deficient. We're not screening pregnant women for iron specifically. And we know that going into and having a pregnancy, giving birth to a child iron deficient is associated with not only increased maternal morbidity and mortality, but also neonatal morbidity and mortality. And then she has her child, which we know that children who are born to mothers who are iron deficient are more likely to be iron deficient themselves. And there are studies showing that they also are at risk for neurocognitive effects from not only their own iron deficiency, but their mother's iron deficiency as well. So changing gears a little bit, I wanted to talk about how we define anemia and how we define iron deficiency. And I think this is a beautiful definition from the World Health Organization, right? About how anemia is just not having enough red blood cells to meet our body's physiologic oxygen carrying needs. That's beautiful, beautiful, beautiful. But anybody in the room who's ever sat in front of a patient knows that that's not how we diagnose anemia in a patient, right? There is no way for us to diagnose anemia in a patient this way. So the World Health Organization, in addition to this beautiful definition, gives us some hemoglobin cutoffs for men and for women, which you can see are different. Men, we say, are anemic at a hemoglobin of less than 13. Women, we say, at a hemoglobin of less than 12. So why is that? Why are they different? Well, if we look at hemoglobin values across the lifespan, you can see here from this figure that girls and boys are roughly equivalent up until the point of puberty. At puberty, males are exposed to more testosterone. We know that's associated with erythrocytosis. Their hemoglobin goes up, all very appropriate. But as you can see here, the girls, their hemoglobin goes down, and that's due to menstrual blood loss and iron deficiency from menstrual blood loss. There is no study, there is no evidence that says that once you become childbearing potential, you need less hemoglobin or you need less iron. We just tolerate this. And so throughout the course of the childbearing years, women have lower hemoglobin, women have lower iron, often dismissed, often not even presenting to care. And then after menopause, they build back up their iron stores. Men are exposed to less testosterone and the values converge again. So this is where, these population-based studies, these are why our numbers are different for defining hemoglobin cutoffs for anemia in men and women. And this is what we do throughout all of medicine. So this is something that I didn't think about that much until probably 5 years ago. But reference ranges, right? We use these throughout all of medicine, and these provide us context to interpret values, right? So anyone who's a clinician can say, you order your lab tests, and then you look for the little red flags that tell you that something is off, right? And some of us, depending on the lab, we might click on it to see the actual number, but mostly we like those little red flags to say like, hey, something's wrong here, right? And in certain disease states, including anemia, it's actually how we define it, right? So the World Health Organization says below this cutoff, or your lab, has a similar, maybe a slightly different reference interval. And you're not going to really probably diagnose someone with anemia unless that little red flag pops up. So thinking about reference intervals and how these come to be, they actually haven't been around as long as you would think. They started being used in the 1960s and are basically just a measure of blood analyte within a patient, within a reference population, using a Gaussian distribution is how we define them. So what does that look like practically? Well, depending on your lab, sometimes you may have an instrument that you get all of the reagents, you get your instrument, and you use the manufacturer's reference interval that they've created. Some labs create their own, but basically what that looks like is that somebody goes out into the community, gets 120 people, measures the hemoglobin in those people, and then graphs it, if it's normally distributed, on a beautiful graph, and cuts off the bottom 2.5% and the top 2.5% and says, this is your reference interval. But we already talked about, right? Like iron deficiency is super, super prevalent, especially in menstruating people. And people aren't presenting, people aren't diagnosed. And so these people are included in this sample that we're getting to define things. And these reference intervals, especially in hematology, are usually like this, where they can differ based on the age of the patient, the sex of the patient. Historically, they've also differed based on race and ethnicity. I spoke at the WHO years back, and they have now removed, incorporating race and ethnicity into their hemoglobin cutoffs appropriately. But they still have this sex-based hemoglobin threshold based on flawed data. So looking at the WHO criteria specifically, if you go to the WHO website, you can look at this yourself. These thresholds of 12 and 13, differential for men and women, were set back in 1968. And if you look at the WHO website, they cite 4 publications in support of this. Well, if you read the 4 publications, 3 of them kind of look at other things, and one of them specifically looks at men and women, hemoglobin values, creating reference intervals. And great, right? So they were in Scandinavia, they got some healthy people. Again, how we define healthy is kind of a matter of debate and quite variable between labs and studies. But they got some men and they got some women, and they graphed these nice normal distributions, and they made the cutoffs. But they were actually brilliant back in the 1960s. And they recognized that there was probably a lot of subclinical, unrecognized iron deficiency in their so-called normal population, right? So they kind of said, maybe in the men and the women, we don't know, but we probably shouldn't make a hemoglobin reference interval without taking this into account, because we know iron deficiency happens commonly. So they moved on after they'd made their reference interval, and they gave everybody, well, a subset of the people, to make another reference interval, iron, both men and women. And what they found was in the women, so you can see here, I don't know if my pointer works. Oh, no, it doesn't work. Uh-oh. Sorry. So what you can see here is the continuous line is the curve for the women prior to getting iron replacement. And the dashed curve is the women post iron replacement. They did the same thing for the men. There really wasn't much movement because there shouldn't really be much iron deficiency in men. There's not a great blood loss route. But as you can see here, when they supplemented the women appropriately with iron, there was a shift to higher values and really disappearance of most values under 13, shifting what should have been the reference interval for men and women to converge more closely at 13. This is not to say, because a lot of people get a little bit out of shape when I say this, this is not to say the higher end should be different, right? So we know that testosterone increases erythropoiesis. Like, we're not saying anything about the higher end, but there's data to support that if you get rid of iron deficiency, the lower limit of normal is much closer in men than we currently use. So we're using flawed values to underdiagnose anemia in women. And what about iron deficiency and how we define iron deficiency? So if you read articles, they'll tell you that bone marrow biopsy is the gold standard for diagnosing iron deficiency. So we'll take a poll in the room. Has anybody ever seen a patient that has ever had a bone marrow biopsy done to evaluate their iron? Oh, we got one, two. Okay. I've never actually had people raise their hand at that question, so this is exciting. We'll have to speak later. But, right, we don't typically do a bone marrow biopsy to evaluate iron. We have other ways, most commonly serum ferritin. It's a flawed test, but it's probably the best that we have. And again, laboratories do reference intervals for ferritin in the exact same way. They go out in the population, they get a healthy group of people, and they make a curve. And the World Health Organization has some guidance for us. They say that for children, ferritin levels less than 12, and for adults, they actually don't have separate thresholds for men and women, which I think is good. But they say less than 15 in an adult without inflammation would be consistent with iron deficiency. But how should we define iron deficiency? So I think about iron all the time. I work with a lot of people who think about iron all the time. And if you ask any hematologist that is focused their career on iron deficiency, most of them will say that for adults, we should be defining iron deficiency without inflammation, without heart disease, without renal disease, like in a generally well population, a ferritin of less than 50 would be consistent. And this is because we know that there are studies that show that around 50 is when our gastrointestinal absorption of iron returns to baseline. We know that symptom-wise, around 50 is when symptoms like fatigue start to improve, and there's kind of an inflection point there. And then there's also lots of physiologic studies that show biochemical markers of iron deficiency also change around this inflection point at 50. But that's not how we define iron deficiency. So I'm really ashamed to say that this is how the University of Michigan defines iron deficiency currently. I've been trying to change this for 3 years. It's a slow process. But as you can see here, the lower limit of normal for women is 6. That is so sad, right? You're a woman, you've been dismissed, like, oh, you have fatigue, you probably need an SSRI, you probably should exercise more, eat better, lose some weight, sleep more at night, right? It's anything but like a medical problem. And then maybe you finally get someone to send some labs, and maybe, I mean, this is like a stretch here, right? But maybe someone actually sends a ferritin, and then it comes back at 6. They're like, you're good. You're good. You're totally fine. No problem whatsoever, right? Horrific. Really, really bad. So this is a great study by a good friend of mine, Michelle Scholzberg, who works in Canada. And she looked at all of these ferritin reference ranges that had been published. And as you can see, they're kind of all over the place. The red ones are for females only, the blue are for males, and the green are generally for when they combine them. They're all over the place. But what's interesting in this study is they actually looked and they said, okay, so we are looking at these ferritin reference intervals, but like, how are we creating these, right? Like, they wanted to know, like, who are these actual populations, right? We didn't just go out on the street and pick the first 120 people we saw. Like, they must have asked some question, like, did they just say, are you healthy? Yes, no, like, what did they actually do? And they looked at a bunch of different things that are associated with a higher risk of iron deficiency. They looked at whether studies asked about heavy menstrual bleeding. They looked at whether studies asked if you'd ever heard of blood transfusion. They asked, all of these different things that would be ideal, but are maybe a lot to ask depending on who you're talking to. But the one that was most commonly used, which would seem appropriate, I think, to most people in the room, is ruling out someone based on their hemoglobin, right? So if we have someone off the street and they say that they're healthy and we're going to use them for our ferritin reference interval, maybe we should make sure they're not anemic. Seems a pretty low bar, not to include anemic people when you're making a reference standard for iron deficiency. Just, seems reasonable. Over 40% of the reference intervals didn't even do that, right? So over 4 out of the 10, out of every 10 reference interval didn't even check a CBC and make sure the patient wasn't anemic, right? I don't even know what to say about that. So unfortunately, these things reinforce each other, right? So we know iron deficiency is overlooked. We know that these patients aren't being diagnosed. There's no universal screening. If you were to ever even benefit from getting a lab, probably your provider is going to say it's normal because you're at 7. And so this perpetuates this cycle. And even if you do look at a CBC to rule people out, if you use this 12 cutoff, which probably is not accurate, you're also going to include people that probably shouldn't be included. But there are a lot of, so like, this is crazy. In my mind, this is crazy. This makes no sense. We can just change this. This is a systemic thing, right? This is all in place. This is bigger than all of us. It's at hospitals. It's at commercial labs, everywhere you go. This is affecting so many patients everywhere. We should be able to change this. But it's difficult, right? Because it is so big. And then you have things like when I presented at the World Health Organization, it was on a meeting about anemia. They were putting out their new standards, which we got them to remove race and ethnicity. But they were talking about all different kinds of things about anemia. And one of their concerns with removing race and ethnicity, because they used to have this chart, I should have put it in my slides, but they used to have this tiny little, it looked like it was made in Word or something, a little chart, and it said hemoglobin should be 12 for women. That was like their big guidance, 12 for women, 13 for men. And then it said, if you're a Jamaican girl between 13 and 14 years of age, this is your correction factor. If you're a Thailand man, this is your correction factor. Like they had like 10 different groups, but only 10. And I guess if you're a 15-year-old Jamaican girl, that didn't count. But if you're a 13 or 14-year-old Jamaican, like it was just like so absurd, right? Well, they got rid of all of that. But people were really on this call up in arms about the idea that we weren't going to use race and ethnicity to define anemia because all over the world, we have these programs, right? So this is one of the biggest goals of the World Health Organization up here, number 2 on their list of things, goals. This was supposed to be, I think, by 2025. It hasn't happened, so I guess maybe they'll change the date. But they wanted to achieve a 50% reduction in anemia in women of reproductive age, right? So if we historically have defined anemia in women as less than 12, and then we say, wait, like even the publication that you cite to support that says it should not be 12, then all of a sudden we have millions and millions and millions of women worldwide that are anemic just making that change. And you're trying to have a 50% reduction, but I've just like doubled the number of women or, increased the number of women by 50% that we're diagnosing. So there's a lot of political and organizational and bigger picture barriers to making change. But I think there's still hope that we can make change. So as I mentioned in my disclosures, the American Society of Hematology is currently working on iron deficiency diagnosis guidelines. We have them all created. They're going to be going out for public comment end of this month, early next month. So look out for those. Please give us feedback. But that hopefully will be helpful as there hasn't really been consensus on defining iron deficiency. My friend I mentioned earlier, Dr. Michelle Scholzberg in Canada, I was involved in her Raise the Bar initiative, which was a over 5-year process where she worked to change ferritin reference intervals. So actually no longer calling them ferritin reference intervals, but calling it a ferritin clinical decision limit, right? Because when you think about these ways that we define things with this normal curve, it becomes even more absurd if you think about other conditions, right? So if we thought about hypertension, right? Like what if we defined hypertension, like what your blood pressure should be under? We just took everyone in the United States or every adult in the United States, right? And then we made this nice bell curve. Then we would accept like, well, probably, I don't know what that would end up being, but like much higher probably than we know is clinically appropriate. Same thing with BMI, right? The rates of obesity are high, the rates of hypertension are high, the rates of all these things are high. We can't just make a normal curve and say like, well, I mean, as long as you're in the middle, then it's fine. If your BMI is 35, no worries. It's good. Everything's good here, right? Or your blood pressure is 150 over 90. Like that's good because you're, not in the worst 2.5% in America. But she actually was able to change all of, or the vast majority of labs now in Ontario province, which is quite large, now define iron deficiency in all adults as a ferritin less than 30 and a ferritin of less than 20 in all children. So that actually went live a year ago. And we've done some work looking at kind of acceptability of that. And now that it's been in place for a year, they actually have circled back with the labs to see if there have been issues, and there surprisingly have not been. So I think the concern with this is that obviously there's going to be more people diagnosed. Whether we have the capacity to see and treat all those people is a whole nother issue, but they have been able to do it in Ontario and haven't had issues. So what about patient blood management? First of all, how cool is patient blood management? I mean, what? I am not a patient blood management expert. I knew very little about patient blood management, and now I'm like kind of obsessed, but it's my understanding, and please correct me because as I said, I'm not a patient blood management expert, but patient blood management is excited about optimizing erythropoiesis, is excited about minimizing blood loss, and is excited about making patients able to tolerate anemia, maybe at lower levels. So I think iron deficiency fits in so well with all of this. I think if, in a crazy hypothetical experimental state, you could maybe say that iron, managing iron could increase your tolerance of anemia, but because our bodies, would take all of our iron and use it for, I don't know that iron is so much involved with increasing tolerance of anemia, but I did want to talk about how it can be very important for optimizing erythropoiesis and minimizing blood loss. So others in the room are probably more expert and know this better than I do, but in the preoperative setting, I think, iron deficiency, and really when I say all of these different settings, I think in an ideal world, we would actually screen people who are at high risk for iron deficiency and treat them like way before they need surgery and like way before they have a baby, and right, because there's a lot of data that shows when we identify them right before surgery or we identify them in the third trimester, a lot of what we do is a little too late. So preoperatively though, we know women compared to men have a lower circulating blood volume. So if they have the same blood loss for a procedure, that's a higher proportion of their blood volume. And some studies have shown, at least within total hip replacement, total knee replacement, and CABG, that this likely leads to increased transfusions. And this isn't the whole story, right? There are other factors such as the bypass circuit and dilution and other things, but this is definitely part of it. And this was a really nice study, I thought, looking at cardiac surgery specifically, and looking at over 6,000 patients that underwent cardiac surgery. And they looked at kind of the blood transfusions between males and females. And so as you can see, the red is females and the blue is males. And so more women received transfusions, and these were intraoperative transfusions. And there was a very clear negative correlation between the preoperative hemoglobin and the risk of having a transfusion. And then they did this really nice logistic regression on the right, where they basically looked at how they could decrease every individual's probability of getting a blood transfusion to less than 15%. And what they found was that for women, in order to decrease their risk of a blood transfusion to less than 15%, their preoperative hemoglobin needed to be 13.3 versus males where their preoperative hemoglobin needed to be 12.7. So based on this data, as well as some other data, there was an international consensus statement that was published in 2017 that does suggest that when evaluating or treating anemia preoperatively, that we really should be using a target hemoglobin of less than 13, or if you're from Canada or Europe, 130, to minimize the risk of transfusion-associated unfavorable outcomes. And I think it's interesting when I was, finding this literature that this mimics, like if we just use the actual citation from the WHO and define anemia sex agnostically, that we would be in the same spot. But people have looked at this to see, what would this effectively mean if we're using a cutoff of 13 versus a cutoff of 12 or 13. And again, I think this is not these patients are far from needing a transfusion. I think this is like, why are you anemic? And if you're iron deficient, we can give you treatment for that and we can optimize you prior to the procedure. But this particular study looked at 610 patients that were going to be undergoing elective surgery and what it would mean if we use that different cutoff. And what they found was that a third of the women in this study actually fell into that 12 to 13 range. So a third of all the women would have been diagnosed with anemia versus if you use the WHO cutoffs. And those women actually would have represented, a third of them, they represented a third of the patients who ended up needing transfusions. So clearly this is a group that if we were able to diagnose them preoperatively, hopefully we could prevent them from being in that transfused group. And then this is just looking at that further and looking at what it would actually do to the prevalence of preoperative anemia. So the dark black rectangles are using the WHO criteria, the differential 12 and 13 for women and men. And then the gray are for using a sex agnostic 13 for everyone. And so clearly increasing the rate of preoperative anemia. But I think why would we not want to identify patients that are at risk of needing transfusion and optimize them prior to that happening? There's a lot of literature out there on trying to optimize iron perioperatively, and the data is definitely mixed, but there is some data. There was a recent propensity matched cohort study looking at preoperative IV iron, which did find lower mortality at 30 days postoperatively, a higher hemoglobin level 30 days postoperatively, and definitely reduced red blood cell transfusions. And then there also was an even more recent systematic review looking at postoperative iron, and that it can be very helpful in reducing further transfusions postoperatively versus preoperative iron in the systematic review was more helpful for hemoglobin recovery. So thinking about optimizing erythropoiesis in other situations, I think that in pregnancy, we're really failing patients. So FIGO is like the big international obstetrics and gynecology organization. They actually say that pregnant women should have dedicated iron testing as early in pregnancy as possible and treatment of iron deficiency. ACOG says, no, you can check a hemoglobin. Studies have shown that the vast majority of iron deficient people in pregnancy are not going to be identified with a hemoglobin because they are not anemic. And there have been other studies that show that in order to not be iron deficient by the end of your pregnancy, you need to have a ferritin in the first trimester of greater than 60. That's like no one, right? But we don't check either. So we can just ignore it and let everyone be iron deficient. And then we say, and then the U.S. Preventive Task Force says, no, there's not enough evidence to screen asymptomatic patients, which is a fascinating statement because symptoms of iron deficiency would be like fatigue. I don't know about you. I was super pregnant when I was really fatigued. I was really fatigued during pregnancy. Lightheadedness, dizziness, cognitive, whatever. Like all of the symptoms kind of overlap iron deficiency in pregnancy, but we're not going to screen anybody. So that's all right. In Canada, they have, at least in some hospital systems, enacted what they call Iron Mom, which is a maternal iron optimization that you can see up on the screen. Basically, it's just actually checking iron during pregnancy and then treating patients appropriately when they're iron deficient. And with the institution of this quality improvement toolkit in women during pregnancy, they were able to decrease transfusions in pregnant people. So, transfusion during pregnancy decreased from 1.2 to 0.8%, and then postpartum transfusion also was decreased from 2.3 to 1.6%. And there have been a number of other studies trying to look at how best to optimize erythropoiesis during pregnancy. This is looking at third trimester treatment of iron deficiency. And I think if you're in the third trimester, oral iron is probably not going to be sufficient to help your baby at that point. But this comparative study of IV iron in 50 women third trimester versus oral, found a greater increase in hemoglobin with IV, and then also a lower rate of blood transfusion, with 6% of those receiving IV iron being transfused versus 18 with oral iron. And then lastly, this is looking again at, this was actually a very small randomized control trial of women who had had postpartum hemorrhage, severe postpartum hemorrhage, and who received either IV iron versus a red blood cell transfusion. And so the continuous line is the iron, IV iron set, and then the dashed line is the blood transfusion set. And as you can see, on day 1, the hemoglobin was, higher with red blood cells. Nobody's surprised there. But then there was no statistically significant difference through the first week. And then as you can see, going out from 1 week on, there was actually a much higher hemoglobin in the group that received IV iron. So definitely a role for IV iron in severe postpartum hemorrhage over blood. And then in the population that I see, there's definitely a role, I think, for optimizing erythropoiesis in heavy menstrual bleeding. This can be quite severe and life-threatening at times. There was a retrospective analysis of 115 women who got red blood cell transfusion and 100 women who received IV iron. And the two groups really were very similar and had a similar increase in hemoglobin. And then there was also a case series of 19 women with very severe anemia. So everyone in the study had a hemoglobin of less than 5 on presentation, but the mean hemoglobins were in the 3s. And all these patients received treatment for their heavy menstrual bleeding, right? So probably hormonal or antifibrinolytic treatment to stop the bleeding, sometimes surgical or procedural hemostasis. They used ESAs and IV iron, and the patients all did really quite well with that. So then thinking about the general population as a whole, I think, there have been a lot of studies about IV iron versus red blood cell transfusion. I will say in my own practice for iron deficiency, I can't remember the last time I transfused someone. Typically, if we're able to stop the bleeding or address the underlying issue, they are fine with just getting iron. But this meta-analysis did show that IV iron is a little bit slower than red blood cell transfusion, but is more sustained. And so red blood cell transfusion was just most effective in the immediate less than 1 week term. So then lastly, I wanted to talk about minimizing blood loss, which I don't necessarily know that we all think about when we think about iron deficiency. But there's a lot of data that shows that anemia and iron deficiency anemia are significant risk factors for experiencing postpartum hemorrhage. So severe prenatal anemia is associated with postpartum hemorrhage. And for patients who experience postpartum hemorrhage, if they have prenatal anemia, they're actually 6.7 times more likely to die. And I can think of very few things in life that are sadder than dying while bringing a life into the world. And this is just something that shouldn't happen, which is, again, why I feel very strongly that pregnant women should probably just be identified and treated appropriately. But here we are. So clearly this link between iron deficiency and anemia and postpartum hemorrhage, and there's probably lots of things that go into that. But I think that there is more and more data showing that iron deficiency likely has hemostatic effects, specifically on platelet function. So this was a really nice article published in 2024, where they did studies in a mouse model of iron deficiency, and were basically able to show decreased platelet aggregation and secretion to all agonists that were tested in an iron deficient mouse compared to a non-iron deficient mouse. They also showed that mice that were iron deficient had lower expression of P-selectin, which is a marker of alpha granule release platelets, and then also showed diminished adhesion and spreading. In this same paper, they then took patient samples of platelets and were able to show that treating patient platelets with iron actually promoted platelet activation and function in a concentration-dependent manner. So I think, this is possibly one of the links between iron deficiency and anemia and postpartum hemorrhage. There are probably others, but something that I think probably deserves more study. Iron is such a fascinating thing where there's also some data that maybe increases your risk of thrombosis. So lots of things that iron can cause problems with. So in conclusion, iron deficiency and iron deficiency anemia are incredibly prevalent across the world, but including high-income countries like the United States, especially in those who menstruate. Current definitions, both for anemia and iron deficiency, miss a huge proportion of the people that are affected. Not to mention the fact that lack of screening, we're probably missing a huge proportion of those affected. But identification and treatment of iron deficiency and iron deficiency anemia can help optimize erythropoiesis as well as possible positive effects on minimizing blood loss. So with that, I'm happy to take questions.
All right, hello. All right, don't be shy, folks. You have a world expert here in front of you. So if you have questions, step to the microphones, please. So otherwise, you're gonna have to hear me ask questions, and I don't think you want that. So please ask questions. Sherry.
Yes, thank you, Dr. Weyand. So I have first a compliment, a little fangirling. So big follower. So thank you for everything that you've done in this space. A comment, I have a group of nurses here and some others in the room that have been been working on some academic projects. We've met with Michelle, so you've been a real inspiration, your work to us, and we have some articles that we are working on in projects to try to also populate the nursing literature, so thank you for that. And then my question, you're probably aware that a group of folks representing patient blood management have worked on a project, both a policy brief and an implementation guide with the World Health Organization on PBM. You've clearly had conversations and meetings. I feel like there's this sort of cognitive dissonance, though, between some of these very clear facts to us, and yet what we see every single article, everywhere, every guideline start with these two hemoglobin thresholds. So in one sense, I feel like the WHO has endorsed this PBM work to say, yes, we believe in all of this, and we agree that there's this disparity and this what we call structural sexism, right, in these hemoglobin thresholds. You've had also that conversation, yet there's no marriage. Any thoughts or suggestions of what we do with the WHO? And thank you.
Yeah, no, thank you so much. First of all, fangirl of yours. You obviously have done so much here. It's very impressive. And I'm so glad that you're working on things in this. Yeah, I think it's really hard with the WHO. I think there are a lot of different groups that are trying to approach them in different ways, including like FIGO, and like we're trying to have more collaborative discussions. I think part of the issue is I think part of the problem is is under nutrition for the WHO. It's not even under, hematology or women's health or any of these different things. It's like, oh, iron deficiency is a nutritional issue. And that is true somewhat everywhere and very much true in other areas of the world. But I think it also doesn't, do you know what I mean? Because then there's no hematologists that are typically involved in the discussions. There are not gynecologists and obstetricians, right? It's typically their nutrition experts who I don't think have any sense of any of this. And meeting with them, speaking at their meeting before, I was just shocked. Like, I was so excited. I was like, oh, I'm speaking at the World Health Organization. And I'm like, I can't believe this is like such a big deal. And, it was like, they're up on this pedestal. And then I went to the meeting and I was like, they're not that smart. Do you know, like, and not all of them, but it was just, do you know what I mean? It was like we talked about like race and ethnicity or social constructs, and this is why it doesn't make sense. And there's all this data that shows it's not genetic, like, right? Race and ethnicity are not, like, a white person and a white person, like if you look at the genetics, it just doesn't make any sense. These are not biologic constructs. Like, we can't use these. And then they were like, so what should we put for Thai people? I was like, did you black out while I was doing it? Like, what do you mean? What should you put for Thai people? Like, you know what I mean? Like, so I think there's just this disconnect, and the people there just being focused on different, you know what I mean? It was like, that was the first they'd ever heard any of that information. So I think they just need to keep hearing it and from different places. Good question. Yes, exactly.
Go right ahead.
Hi, I also am an OB nurse, and so postpartum hemorrhage is my forte. Our problem has been getting insurance to provide funding for or coverage for IV iron treatments unless the hemoglobin was less than 10. And wondering what kind of ferritin levels you've been able to get coverage for a pregnant 11, which I'm still not happy with. I want all of my patients over 12. And I've got research to support that they have less postpartum hemorrhage if they come in with a hemoglobin over 12.
Yeah, no, I think the insurance piece is really hard. So the American Society of Hematology is working next on like treatment. And I think they probably will cover some of this, which hopefully will give, I was also a part of the von Willebrand disease guidelines that came out like in 2021. And I've used those repeatedly when insurance is like, we won't pay for this. And I'm like, here is this guideline paper that, you know, is universally accepted. And so hopefully things like that will be helpful. I think it's crazy too, because there's an amazing hematologist at Yale who does a lot of cost effectiveness work and has found like screening is cost effective and IV iron, like all this, it's actually more cost effective to do that, but the insurance companies just look at it differently. Yeah. No.
We'll do Jenny first and then go to Melissa.
Hi, I think it's great that you're covering the concept in general, but in general, you cover the younger patients, the adolescents and the women. So I'm just kind of curious to know what your typical treatment plan for them is, because there's always talk about IV iron, and I don't know what you're doing for this large young population.
Yeah. So, and so you mean like adolescents in general, like when I talk about like the 40%?
Yeah.
Well, so I think, to be honest, like most of those people are not even being identified, right? Like we have the CDC data that shows in the general population, that's what it is. I think that the people who are most severe are the ones that make it to me. I do use a lot of IV iron in my practice just because the rate of side effects in oral iron and with obesity influencing, we have many more obese adolescents than we previously did. And so it just becomes like very easy to replace with one dose of IV iron and treat the underlying issue. I think that's a huge thing. I get referrals all the time where people are mystified, like what could possibly be happening? Like we give them IV iron and they do better and then they drop again, but they're bleeding for 4 weeks of the month. So of course they drop again. So I think managing the underlying issue. But I think most of those people aren't being identified. So that it would be an issue, right? If we started screening everyone, which is a whole nother situation. Yeah.
Melissa.
Hi, yes. Question about your colleague in Canada who was able to get the hospital system to change the ferritin level reference ranges. Any insights or tips for a nurse PBM implementer in a large hospital system on how someone might go with starting an initiative of getting those ferritin levels changed to not less than 6, but at least less than 15, if not less than 30?
Yeah. So I've been working with my hospital for 3 years, and I feel like one thing that was quite helpful is actually when Ontario did it. There's a lot online about what they did, and they have a really nice website. If you Google like raise the bar, like Ontario or something, they have a really nice website where they have all this material about like the background of why they picked the cutoffs and kind of how that all worked, and also even like verbiage for like what it says below the results. It does flag as abnormal in Ontario less than 30 because there is a lot of evidence that people react to the abnormal flag, they're not looking at the number. So even if you write underneath, like if you don't flag it as abnormal and then you write underneath like this is abnormal, no one's reading that because they're not even looking at it. So providing them that was super helpful at my institution. And then also I think really framing it as like a clinical decision limit, because I think laboratory people, like with my lab particularly, they were like, so who should we use for the reference interval? I'm like, no, we're not going to be able to like create one that makes sense. We just need to like use it similar like cholesterol, right? We don't use a reference interval for cholesterol. We say we know that there are bad outcomes underneath this level, and so that's where it is. So I think using that terminology has been really helpful for the lab, and that was also from Dr. Scholzberg's advice. With the American Society of Hematology working group, we're trying to work with like Quest and LabCorp and trying to get them. But I think that will take the ASH guidelines actually coming out before they're probably willing to make. But hopefully, like if those places start doing it too, it will be. And so with my institution, I actually most recently, like it's happening because I was like, I'm on this guideline panel and we're gonna like, do you want to be the last people to do this? Like all these other places, and like, you know, if you can name some institutions that are doing that, I think then they get a little bit like, oh, well, we don't want to be, you know, last.
Thank you.
All right, I think we have just time for one more quick question, and those who haven't asked their question, we'll have time afterwards to talk. So go ahead, real quick.
Thank you. I think it's a much easier problem in terms of diagnosing iron deficiency or iron deficiency anemia when you have the cutoffs of say 120 for females or 12 and 30 ferritin for females. But I was wondering if you could provide some clinical tips for that kind of gray zone range that you talk about where the ferritin might be between 30 and 50. Like, are you able to get to 50 with everybody? And then on the hemoglobin side, well, 120 could be too low, but what is, like, how do you gauge what the right value is? Because I have the experience of you'll have a patient come in, her hemoglobin is 121 or 12.1, ferritin 6, you give them a bunch of iron, they come back, their hemoglobin's 140, their ferritin is still 6.
Yeah, so with the anemia thing, I find that I don't think about it as much because like I'm going to treat the iron deficiency regardless of whether they're anemic. And I also think that a lot of the symptoms occur like before they're anemic. So, but I think for the ferritin, it is really tough. And I think that part of it is that we're measuring ferritin, but we're not measuring like tissue iron, right? And so I find in my practice, like I have people who will call me and they'll say, I know my ferritin is less than 50, and we check and it's less than 50. And then I don't hear from them. And then the next time I hear, I know it's less than this. And I have other patients who I see and their ferritin's like 20, you know, and somebody got it and they're like, I have 0 symptoms. I have nothing. Like, I am happy. I'm living my best life. Like, great. Like, you seem to be, you know, I'm not going to treat you. Like, if you're feeling, now if their ferritin was like 3, I'd be like, well, like for the future, we need to do this. But if, you know, they're feeling great and not having any symptoms, then I wouldn't necessarily like strongly, you know, be in favor or like make them take iron or give them iron. I do think it's really hard to get to 50 in a lot of these patients without IV iron. So I will kind of have a lot of shared decision making with the patient of, I have had patients, so I've had teenage girls who come and they have ferritin between 30 and 50 and they've stopped going to school and they're depressed and, you know, they just have like so many different symptoms. And so I have very honest conversations with the family of, this could be partially due to iron. I don't know that this is entirely due to iron, and it might not be due to iron at all. This is something we can take off the table, right? Like if you are struggling that much and I can give you IV iron once and get you to a good level, we can see, right? And so some of them, it's like, oh my gosh, now they're going back to school. Like that was shocking to me. But then others, it's like, I don't feel any different. My ferritin's now 80. I feel exactly the same. It's like, well, good, then you need workup for something else. So I find IV iron to be helpful in that situation of like, if they have very severe symptomatology of just like taking iron out of because there's all of the symptoms of iron deficiency are so nonspecific. It's like, this could also be all these other things, but if we can take it out of the picture, then it's like, then you know, okay, you need the sleep study or you need whatever else done. Does that make sense?
Great. Hey, thanks again to Dr. Weyand for being here. Thank you, everybody. It's now time to please go take a break with the exhibitors, visit them. They support our conference. Really great time to get to know some of the folks out there and to mingle amongst yourselves and ask any residual questions. Please feel free to come up to the front of the room. Thanks.